types of pain and all. So now we are coming to the management part. So today this session will be taken by Dr. Mary Abraham. She is a neuroanesthesiologist and as well as a palliative care physician. She has a lot of experience in palliative care and anesthesiologist that experience. So now she is working in Max Hospital, Delhi, and also she has conducted a private clinic in New Delhi. She has awarded a achievement award by Delhi Neurological Association for contribution of to neuroscience in Delhi in February 2017, and she has wrote a book on conquering pain. Very happy to have you here, ma'am. Welcome once again. Welcome, and over to you.
I'm audible, no?
Yes, ma'am, you are.
Okay. Can I thank you so much, Shiba and Shri Priya, for that introduction. And once again, I'm happy to take this class for all of you on the WHO step 1 and step 2 drugs, as well as I'll be touching upon the management of neuropathic pain. So can I just share the screen, please?
You already have the sharing rights, ma'am. Please go on.
Okay. 1 minute. Can I, 1 minute? I'm not able to get this by the side. Its broad outline of my talk is the basics of the WHO analgesic ladder. And like I told, I will also touch upon drugs for neuropathic pain. Now, in 2010, at the International Pain Summit in Montreal, a declaration was made that access to pain management is a fundamental human right. And it is right of all people to have access to adequate assessment and treatment of pain by trained healthcare professionals. So it is like one of the rights that we have, like right to free speech, right to religion. So similarly, it is a right of everyone to have access to pain management. And according to this, if there is a failure to manage the pain and take reasonable steps to prevent, alleviate pain, it is deemed cruel, inhuman, and degrading. And in fact, the WHO has given a lot of emphasis to cancer pain, and they have developed policies and strategies to treat it with an emphasis on total pain management. So I think I won't go into total pain management because it would have already been dealt with earlier. So the WHO analgesic ladder was part of that in the sense that it was devised by a group of international experts way back in 1986. It's more than 30 years ago. And it was the basic idea is to make sure that people don't suffer from pain. And subsequent to this, over the years, it has been translated into 22 languages, and it is being used worldwide to treat cancer pain. So we need to know about this WHO analgesic ladder because even today we are using that ladder only to treat our pain patients. So it is a very simple tool. It's well validated. That means it has been found to be effective. And it is a stepwise approach to treat cancer pain depending on the severity of pain. Now, before the WHO ladder, people were dying in unnecessary pain because of two reasons. One was because there was a lot of drug regulation associated with opioids. It was very to prescribe it and to even to store the drug and even for patients to get access to the drugs. It was heavily bureaucratic process was there. So it was not easy to procure morphine, not easy to even prescribe morphine. And that was one reason why morphine was not being used widely. The second reason was that there was a stigma associated with prescribing and taking opioids. Even relatives were afraid to give opioids to the patients because they felt that they will become addicts. Now, with the WHO analgesic ladder authorizing that this is the third step of the ladder, it actually legitimized the use of opioids. And then it paved the way to ease the drug regulations. And it tried, and a lot of the stigma associated with morphine is also not there because the World Health Organization itself has advocated the use of opioids. Now, let us start with a case scenario. A 35-year-old father of two young children. He had a CA lung, right upper lobe. He had deep-seated gnawing pain in the right shoulder with a burning and tingling sensation in the right arm. So there are two different kind of pain he had. One was a deep gnawing pain in the shoulder and then a burning and tingling in the arm. He was unable to sleep. The NRS score during the day was 4 and at night it was 6. So the pain was around mild to moderate pain. In the end, after the presentation, we'll discuss how we manage this patient. So, like I said, the analgesic ladder is applied based on the severity of pain. So we need to assess the pain. Okay. Only then we will know the severity. And we know that for assessing pain, there's a mnemonic called PQRSTU. I think this would have been taught to you earlier, but just see the second S, that is the severity of pain. It is this that is taken into consideration when you're applying the WHO analgesic ladder. Okay. And the other thing that we need to know is the type of pain. Is it nociceptive or is it neuropathic? Now, nociceptive pain is, like you know, because of tissue injury. There is a cut in the hand or there's a cancer affecting the skin and that is causing pain. And that is nociceptive. Here, the neural pathway is all right. It is only the tissue damage that causing pain. The other pain is neuropathic pain. Neuropathic pain is the cancer involving the nerves or the nervous system. Okay, there are two different kinds of pains, and we need to distinguish between both of them when we want to apply the ladder because the treatment of both is different. You can't give drugs that treat nociceptive pain for neuropathic pain. The pain will not get relieved. Similarly, vice versa. You can't give neuropathic drugs when the pain is nociceptive in nature. Okay, so this is what we need to know before applying the ladder. Now, the WHO analgesic ladder that we are using, widely used, is a 3-step ladder. The step 1 is for mild pain where the NRS is less than 4. And in this, you use a non-opioid analgesic along with an adjuvant if required. Now, if the pain is not responding to these drugs, then we move up the ladder to step 2 drugs. Okay, that is for moderate pain when the NRS score varies between 5 to 7. Now, in this, we are using a weak opioid with or without a non-opioid and with or without an adjuvant drug. I'll talk about adjuvant drugs at the end. Okay, just remember that there are adjuvant drugs also. Now, if the pain is not responding to this also, then we move up the ladder to the step 3, which is when we substitute the weak opioid with a strong opioid, along with maybe a non-opioid and maybe an adjuvant drug. So this is the 3-step ladder. Okay, we go up depending upon the intensity of pain, we have to apply the ladder. Is it mild? Is it moderate? Or is it severe? Using this ladder, up to 76% of cancer patients can get relief of pain. Now, what are the salient features of the ladder? Please remember 3 things. One is by mouth, by ladder, by clock. Now, what is by mouth? All these drugs are given by the oral route. That is a standard route of administration, even for the strong opioids. And that is a huge advantage because the drugs can be given at home. It can be given by the caregiver, or the nurse can go and explain to them how to give it and they can take it at home. It doesn't require even a daycare admission or a hospitalization. So that is a big advantage because most of these patients may be at home and receiving domiciliary care. The second important feature of the ladder is it's given by the ladder. That means we start with step one. If it's not getting relieved, you move up the ladder. But sometimes in exceptional circumstances, you can start with step three when the pain is very severe. The third important characteristic is that it is given by the clock. By the clock means it is not given only when the pain comes back. It is given according to the duration of action of that particular analgesic. Now, all analgesics have different duration of action, which is called the half-life of the drug. So it varies between morphine and paracetamol and tramadol or uh, any other drug, it can vary depending upon the half-life of the drug. So if in case of morphine, immediate release morphine, you need to give it every 4 hours because after that, the pain is going to come back and you're not waiting for the pain to come back to give the next dose of drug. You're giving it even before the pain comes back. And that is how you can have a constant relief of pain throughout the 24 hours rather than having peaks and valleys. So that is what is meant by giving by the clock. Another characteristic of the WHO ladder is it is individualized to the patient, which means the right dose is a dose that relieves the pain. It can vary between patient to patient depending upon the severity of the cancer and the severity of the pain. For one patient, he may be having good relief with a total of 60 mg morphine per day. Another patient may require 240 milligrams a day. But in both, it is a right dose because that is a dose that is relieving the pain. So, and also we have to explain that even in case of morphine, if the pain is coming back after 2 hours, you can give what is called a repeat dose of the drug. And that is the treatment of breakthrough pain. That's called a breakthrough pain when it is occurring even before the duration of action of the drug is over. So it has to be, all these drugs have to be individualized to the patient. Then we have to also use adjuvant drugs. I mentioned about adjuvant drugs can be added at every step of the ladder. That is used for specific types of pain. Okay, I'll talk about it when at the end of my lecture. And the last important characteristic is its attention to detail is very important. You have to take into consideration the patient's age, the body weight, the comorbidities, whether the patient is having any side effects. All this has to be taken into consideration when you're prescribing the drugs. Like, a healthy 40-year-old man and an emaciated 80-year-old man. You can't give the same dose to both patients, right? So you have to think about it with a lot of meticulously, you have to give the drugs. Next, please. Next. Oh, sorry. I'm sure. So the advantages of the WHO ladder is that it is simple, very easy to understand. Like I told you how it is simple tool. And also it is implemented worldwide, very well suited for home care. It can also be given for non-cancer pain and also for acute pain like post-operative pain or pain due to trauma. You can apply the ladder even in those circumstances. It's not necessarily only for cancer pain. Now, so this is the drug. I think I'm just repeating this, so I'll go on to the next slide. Now, some modifications of this WHO ladder is there. One is sometimes from the step one, you can move on to step three directly when the pain is very severe. You don't have to go to step two to go up to step three. You can even bypass a step. And sometimes we may have to add a fourth step to the ladder. And that is when the patient is not responding even to the oral opioids, oral morphine, or the oral strong opioids. Then you may have to add another step to the ladder. Okay? And that happens in about, I told you, about 15 to 20 percent of patients. Excuse me. So this is a fourth step of the ladder. And these are the patients who have got intractable pain. So in these patients, what are the modalities that we can use? We can use nerve blocks, we can use epidural injections, we can use a PCA pump, or we can give a neurolytic block, that is, excuse me. So neurolytic blocks are giving agents like phenol and alcohol, which are actually destroying the nerve or the ganglion. So that is a permanent effect it has. Or you can use intrathecal opioids, where the catheter is implanted into the intrathecal space, and directly morphine is given into the spinal canal. Or you can even use spinal cord stimulators. So there are various other options. And these are some of the ones that we are using for patients, okay, who have got intractable pain. So let's discuss the step one drugs. These are used, like I said, in mild to moderate pain, and the drugs that are used are paracetamol, non-steroidal anti-inflammatory drugs, and they can be combined with an adjuvant drug. Now, paracetamol. It's also called acetaminophen, particularly in the Western countries. Now, it acts by inhibiting the enzyme cyclooxygenase, or the short form of cyclooxygenase is COX. So it blocks the enzymes COX-2 in the central nervous system. That's how it exerts its analgesic effect. But it does not have effect on the COX that is present in the periphery. Unlike the other drugs that we are giving, like brufen and aspirin and all, they act on the peripheral COX, but paracetamol acts on the central COX. So paracetamol has only an antipyretic and analgesic action. It does not have an anti-inflammatory action. So how do you give paracetamol? What are the doses? You can give up to 3 grams a day, but the daily dose should be less than 4 grams. And a single dose should not exceed 1 gram. You can also give it as an infusion of 1 gram every 6 hours in very severe pain. It can cause hepatotoxicity, but even in liver disease, you can give up to 2 to 3 grams quite safely. Very good for pediatric use when you can give in a dose of 15 mg per kg every 6 hours. Toxicity occurs only when you give more than 90 mg per kg per day or more than 4 grams of paracetamol a day. Sometimes when the oral route is not feasible, like patients with head and neck cancer or cancer of the tongue or cheek, when they cannot swallow, then you can use a rectal route also to administer paracetamol. The advantages of paracetamol over the NSAIDs that we are using is that it has a very good safety profile. It has no adverse effects on the gastric mucosa, so safely tolerated by patients with peptic ulcer. It has no adverse renal effects, no effects on altering platelet function, so less tendency for bleeding. It can be given to patients who are sensitive to aspirin, who have allergic reactions to aspirin. And also it is safe to give in patients with gout, with raised plasma uric acid levels. But there are drawbacks. And one of the important drawbacks is it's to be given every 6 hours because that is the duration of action of the drug. And also it can cause hepatotoxicity when high doses are given, when there's impaired liver function, when the patient is taking a lot of alcohol in a day, and when the body weight is less than 50 kg, you must give not more than 2 grams a day. So the role of paracetamol in cancer pain, we are very often prescribing paracetamol for patients with cancer because of its safety profile and because it has an opioid sparing effect. That means when you're adding paracetamol to the analgesic regime, you can actually decrease the dose of opioids that you're giving. And it can be added at all steps of the ladder, at step 1, step 2, and step 3. All steps you can give the paracetamol. Now coming to the non-steroidal anti-inflammatory drugs or the NSAIDs. This is a very common over-the-counter analgesic drug. You don't even need a prescription to get this drug. The advantage over paracetamol is it has got anti-inflammatory properties as well. So it is a step 1 drug mainly used for nociceptive pain, that is pain due to tissue injury and inflammation. But occasionally it can even be given for neuropathic pain also. Now, I said that paracetamol acts on the central cyclooxygenase, whereas NSAIDs acts on the peripheral cyclooxygenase, which is a very important enzyme in the pain that is occurring following tissue injury when ultimately the prostaglandins are produced. And it is these prostaglandins that are actually intermediaries in pain and inflammation. So it acts against this prostaglandins. Now, just to summarize, whenever there is a tissue injury, there is a breakdown of the tissues causing release of phospholipids that is converted to arachidonic acid. And COX-2 is the one that converts arachidonic acid into the prostaglandins. And it is this prostaglandins that is causing the inflammation. So this is about COX-2. But there's another enzyme in the body called COX-1. That is the housekeeping or the constitutive enzyme, and it is necessary for the homeostatic functions of our body, like for maintaining the stomach function, the kidney function, the platelet function. So when you give a drug like NSAIDs, it is blocking both these drugs, both COX-1 and COX-2. And because it is blocking the COX-1, it has got undesirable effects because it's blocking the beneficial action of the COX-1. But because it blocks COX-2, it exerts the anti-inflammatory effect. So that you must remember, okay, when you're giving the NSAIDs. So there are two types of NSAIDs. One is the non-selective NSAIDs, which is blocking both COX-1 and COX-2. But there are also selective COX-2 inhibitors that are only blocking COX-2. So the anti-inflammatory effect is there, but it is not blocking the COX-1. So the beneficial effect of the COX-1 is still retained. Okay. Now, the non-selective NSAIDs are, some of them are ibuprofen, naproxen, and aspirin. Okay. They are inhibiting both COX-1 and COX-2. But because of the COX-1 inhibition, it has got so many side effects like GI bleeding, hypersensitivity, and even adverse renal effects. But because it is blocking the COX-2, it has got the anti-inflammatory, analgesic, and antipyretic effect. So the non-selective NSAIDs is a double-edged sword with both adverse and beneficial effects. So the examples I said are ibuprofen, which is given orally in a dose of 400 mg every 6 to 8 hours, or naproxen. These are the two examples. There are more, but I'm only telling two. Naproxen is also a non-selective NSAID. It also can be given orally or as a suppository. Now, as a result of COX-1, the side effects of the NSAIDs are there, like renal side effects, gastrointestinal side effects, and the hypersensitivity reactions. Okay, so you have to keep that in mind when you're giving the non-selective NSAIDs. Now, selective COX-2 inhibitors, I say they are not blocking the COX-1, they're only blocking COX-2. So what are the examples? One is etoricoxib, which is called Nucoxia, in a dose of 60 to 90 or 120 mg once a day. The other one is celecoxib, which can be given a dose of 100 to 200 mg twice daily. Diclofenac sodium is also functionally a selective COX-2 inhibitor. It can be given a dose of 50 mg every 8 hours. But are selective COX-2 very safe as compared to non-selective inhibitors, COX inhibitors? They are safe for the GIT. But where the renal damage is concerned, it can still cause renal damage. So it is not as safe for renal dysfunction patients. But on the other hand, these selective COX inhibitors can be prothrombotic. That means they can cause thrombosis in the myocardial and cerebral vessels, leading to myocardial infarction and stroke. So you have to be very careful when you write these for patients who are high risk for MI and stroke. So what are the precautions that we need to take when we are giving an NSAIDs? We should always give it with a gastroprotective drug like a proton pump inhibitor like pantoprazole because of its effect on the gastric mucosa. We have to be very careful when we give it in patients with acid peptic disease, those with on steroids or coronary artery disease or renal dysfunction. Ensure there is adequate water intake. Avoid NSAIDs when there is dehydration. And also avoid it if there's a bleeding tendency because it can alter the platelet function. And remember, selective COX-2 inhibitors should not be given in patients who are at risk of MI and stroke. Okay, because they can increase the risk of these patients. Now, these analgesics can also be available as gels and creams, like they produce this analgesic effect without the risk of systemic absorption and toxicity. And some of the examples are ibuprofen, diclofenac, piroxicam, ketoprofen. They're all available as gels or creams applied locally. So these are summary of the risk factors for NSAIDs toxicity. That for GI toxicity, you should avoid it in patients with GI symptoms and bleeding. When there's dehydration and when there is concurrent use of nephrotoxic drugs, and when the creatinine clearance is less than 30, you should avoid it, and avoid COX-2 drugs in those patients with risk of stroke and MI. Now coming to the step 2 drugs. I said this is used to treat moderate pain, and it can be combined with a non-opioid and an adjuvant drug. Now, they are not controlled drugs. Although they are weak opioids, they are not controlled drugs like morphine and fentanyl and all. Okay, so you give it for patients, so more easily available, less risk of respiratory depression, and it can be given for pain of moderate intensity that is not controlled with step 1 drugs. So again, the examples of step 2 drugs are tramadol and tapentadol. Now, tramadol, very widely used. I think all of you all are familiar with using tramadol. It has a dual method of action. Because it's a weak opioid, it's actually acting on the opioid receptors and causing the analgesic effect. But it also has an effect on the descending inhibitory pathway of pain by blocking the presynaptic reuptake of serotonin and norepinephrine. So it is quite good for neuropathic pain as well. Now, tramadol, it has got a high oral bioavailability. That means you can give it orally with very good absorption into the systemic circulation. The oral dose is very potent. It's 1/10 as potent as morphine. So if you're giving 400 mg of morphine, then you can divide it by 10. So you're giving 40 mg of 400 mg of tramadol, then you're giving 40 mg of morphine. You have to divide it by 10 to get the equianalgesic dose. Now, even sustained release preparations are available when you have to give it only twice daily. Otherwise, you can give 3 to 4 times daily. But it has got some side effects like nausea, vomiting, dry mouth, constipation, dizziness, sedation. It can also lower the seizure threshold, particularly in patients with epilepsy and those taking tricyclic antidepressants and SSRIs. Now, tapentadol is another step 2 drug. Just like tramadol, it's a newer drug. Action is similar to tramadol. It has a dual method of action, but the side effect profile is a little better, and the dose is also very similar to tramadol. So when you want to combine analgesic drugs, just remember, do not use 2 drugs of the same category. Like we do not combine COX-1 and COX-2 drugs. That means you do not combine brufen with mucoxia. Okay. Similarly, we do not combine a weak opioid with a strong opioid. You don't combine tramadol and morphine or tramadol and fentanyl. But what we can combine are paracetamol NSAIDs with morphine, or paracetamol with NSAIDs, or paracetamol with tramadol. These are good combinations. Now coming to adjuvant drugs. I've been talking about adjuvant drugs from the beginning. So what are adjuvant drugs? Now just remember, cancer pain is not just nociceptive. That is, it's not just due to tissue injury. It can be due to nerve injury, nerve involvement, neuropathic pain. There can be bone pain. There can be bowel obstruction pain. There can be pain due to muscle spasm, or there could be other associated symptoms. So adjuvant drugs are used for treatment of these kinds of pain, the other kinds of pain. That's why it's called adjuvant drugs or co-analgesics. And these adjuvant drugs have got other effects beside analgesic effects. For example, an antidepressant is also used for the treatment of depression and also good for neuropathic pain. Or an anticonvulsant like gabapentin can be given for convulsions as well as for neuropathic pain. So their primary indication is not for pain, but it has got effect for pain. How do you classify analgesic drugs? Is based on the clinical symptoms. You have multi-purpose drugs that can be used for a variety of pains like antidepressants, corticosteroids, alpha-2 agonists, or you have specific adjuvant drugs like neuropathic pain, drugs for bone pain, or for bowel obstruction pain, or for musculoskeletal pain. Okay, so they are called specific adjuvant drugs. Sorry, just 1 minute. Now, what are the adjuvant drugs used for the treatment of neuropathic pain? Now, neuropathic pain, that is pain due to involvement of the nerves or the nervous system, can occur in 40% of cancer pain. So, how do you define neuropathic pain? It is caused by a disease or lesion in the peripheral or central nervous system. And the neuropathic pain ha has got specific properties. It is like a burning pain or a shooting pain or an electric current kind of pain. So that is how you differentiate that this is not nociceptive, but it is a neuropathic pain. So if you look at the pain pathway, this is a very simplified form of the pain pathway. You have the tissue here, okay? And when tissue injury occurs, you have what is called a nociceptive pain. So anything beyond the tissue in the peripheral nerve or in the spinal cord or in the brain, it all comes under neuropathic pain. Okay. So why does neuropathic pain occur in cancer? It is because of the direct invasion or the compression of the nerves because of the cancer, or it can be due to the treatment of cancer. For example, chemotherapy induced peripheral neuropathy. Chemotherapy is destroying the peripheral nerves causing the cancer, or radiation induced, or during surgery if the nerves are cut or injured. And even it can even happen in cancer survivors. Patients who have been cured of cancer still can have neuropathy because of the permanent effect of the damage of the peripheral nerves. So how do you treat it? The first line of treatment is anticonvulsant drugs and antidepressant drugs. Both can be used as a first line treatment. The anticonvulsants are commonly used are gabapentin and pregabalin. The advantages of gabapentin are that it has got a proven effect in neuropathic pain, but it can cause dizziness, sleepiness, fatigue, impaired concentration, and weight gain. So this has to be explained to the patient before we start on these anticonvulsant medication. So gabapentin is much less expensive than pregabalin, but it is easier to titrate pregabalin as compared to gabapentin. Now, antidepressant. This is also a first-line treatment for neuropathic pain, but the analgesic effect occurs in 1 week's time. It doesn't occur immediately after you start the drug. And the analgesic effect occurs even before the antidepressant effects and at much lower doses. For depression, you have to give much higher doses of antidepressant drugs. Whereas for pain, you have to give very low doses. So because many of the cancer patients have got depression and anxiety and insomnia, it is very useful to give these antidepressant drugs in these cancer patients. So the classification of antidepressants are the tricyclic antidepressants. The commonly used drug is amitriptyline or triptomol. Or the other drug is the selective norepinephrine receptor inhibitor, that is SNRI. And the commonly used drug is duloxetine. Or there's another group which is called the SSRI. And that drug example is escitalopram. Okay, all these can be used for the treatment of neuropathic pain. But it has got side effects. The central nervous system side effects are sleepiness, mental clouding, even suicidal tendencies. And the other effects of TCA are dry mouth, acute angle glaucoma can be precipitated. So they can have constipation, urinary retention, orthostatic hypotension, and even tachycardia. So you have to be very careful when you give it in these patients. So we have to be very careful when we give it in patients with heart disease or with prostate enlargement, or even with glaucoma. You have to be very cautious. The side effects of SNRI again are all this: sleepiness, constipation, anorexia, and the drugs uh, that are commonly used SNRI are venlafaxine and duloxetine. And duloxetine, you should be particularly careful when there is hepatic insufficiency. So what are the doses that we use for neuropathic pain? I said we give very low doses of antidepressants. You can start with 10 mg or 12.5 mg, and then you slowly step it up. Anticonvulsants, you can start with gabapentin 100 mg, and then you can go up to 300 and keep going up. But it has to be done gradually, increasing every 5 days. Pregabalin can be started with 75, and again, you can gradually step it up depending on the control of pain. But remember, all these drugs should be adjusted in those who are having comorbidities and those with renal dysfunction. What are the other drugs that are used in neuropathic pain? We can use the NMDA blockers like ketamine. So ketamine acts here at the spinal cord. It is blocking the NMDA receptor and thus preventing transmission of the pain. Now, ketamine is an IV anesthetic, but for pain, you have to give much lower doses. It's called sub-anesthetic doses. So oral ketamine, you give in a dose of 10 to 25 mg. If you're giving subcutaneous or intravenously, then you give in a dose of 50 to 100 mg per day. Then in intractable pain, we give what is called a burst ketamine, then in which we give it using a syringe pump and keep stepping it up every 3 to 5 days till a total of 500 mg is reached. Now, ketamine has got side effects like dysphoria, hallucinations, nausea, vomiting, and dizziness. So you can prevent it by adding a benzodiazepine or a haloperidol. You can decrease the psychotomimetic side effects. Now, local anesthetics are also used to treat neuropathic pain, okay, particularly when it is called intractable pain. So we can give IV Zylocard as an infusion over 1 hour, but the patient has to be kept in the hospital and monitored for the ECG and other side effects of the local anesthetic when you're giving it intravenously. But even topical local anesthetic patches are available called lidocaine patches. So they are called 5% lidocaine patches. They can be applied, but you should not apply more than 3 patches a day, and you should apply it only for 12 hours. After 12 hours, you have to take it out for another 12 hours so that the side effect of the local anesthetic doesn't happen. So if you look at the neuropathic pain ladder, the first line treatment is, like I said, antidepressant like amitriptyline, anticonvulsants like pregabalin and gabapentin, and SNRI like duloxetine or lidocaine patch. The second line treatment will be opioids and tramadol. And third line also, you have got drugs like ketamine and baclofen, etc. Now, corticosteroids. It's a very useful adjuvant drug, and it's used to treat so many varieties of pain, not just neuropathic pain, but also bone pain, headache because of intracranial metastasis, pain due to obstruction of the hollow organ like a bowel, or even pain due to spinal metastasis. That is why it's called a multi-purpose analgesic drug. The beneficial effect also is that it will give a sense of well-being, improves the loss of appetite and malaise, and improves the quality of life. And it acts by decreasing edema by its anti-inflammatory effect, and it's also a mood elevator. But there are side effects of steroids. We should keep it in mind. And the drug that is commonly used is dexamethasone. Because it is a long duration of action, you have to give it only once a day. It has also got less mineralocorticoid effect. That means less chances of fluid and water retention. The other drugs that are used are prednisolone and methylprednisolone. So always remember, give the steroids in the morning, because if you give in the evening, it can cause insomnia. And the dose of dexamethasone is 4 to 8 mg once a day. You can give it for 5 to 7 days. But remember that you have to give a gastroprotective drug along with the steroids, because it can cause stress ulcers. The other drug that we can use is baclofen. This is given for neuropathic pain associated with spasticity. Okay, so that's the useful drug. For bone pain, there are a variety of drugs that can be given. They include corticosteroids and NSAIDs. Calcitonin is not very often given because the latest review shows that there's no significant improvement in pain. Then you can give bisphosphonates and denosumab or palliative radiation. That is how you treat bone pain. So these are the bisphosphonates versus denosumab. Zoledronic acid is a bisphosphonate. Now it's very cost effective. This is very expensive. And this can be given IV, this can be given subcutaneously. Here there is more risk of renal toxicity. With denosumab, there is less risk of renal toxicity. Now for bone pain, you can also use palliative radiation, which can cause considerable decrease in pain. So that is one of the useful therapies for bone pain. Now, pain due to bowel obstruction, you can give steroids. You can combine with an octreotide, like and also an anticholinergic drug. We can also give all three also sometimes as a combination to treat the pain due to bowel obstruction. How do they act? It decreases the edema of the bowel and decreases the peristaltic movement, and that is how it's relieving the pain. But the effect of this is not long lasting. So it's advisable to give in terminal cancer patients where the effect is patients are not expected to live long, because after a few days, the pain may come back. The other adjuvant drugs that we can use are skeletal muscle relaxants like tizanidine, chlorzoxazine, and thiocolchidoside, or you can use neuroleptics when there is hallucination and delirium. You can use olanzapine, antibiotics, sedatives, anxiolytics, laxatives. These are all other adjuvant drugs that you're giving. So let's come back to our case scenario. Now, like I said, we need to first do a comprehensive pain assessment and also take a psychosocial and spiritual history. Now, in this particular case, the intensity of pain was mild to moderate. He had both types of pain. He had both nociceptive in the shoulder and neuropathic in the arm. And the pain was worse at night, so it had a temporal nature. And also, if you unveil the meaning of pain in this gentleman, he was a father of 2 young kids and he was unable to sleep or work. So he may be having functional, emotional, social, and financial concerns as well. So how do we manage this patient? You can start off with WHO step 1 drugs because the pain was mild to moderate, and also add on adjuvant drugs to treat the neuropathic pain and also to treat the insomnia. So what we would give is a combination of paracetamol with NSAIDs, with a gabapentin, with a sedative. And at the same time, we have to give him psychosocial support for his financial and social concerns. To summarize, the WHO analgesic ladder is a sheet anchor for cancer pain management. It can also be used for non-cancer pain. Very simple, easy to implement, used worldwide, and it has legitimized the use of opioids in cancer and non-cancer pain. Thank you.
Thank you, ma'am, for the wonderful session. Anybody have any doubts on this presentation, please ask, ma'am. You can clarify your doubts. So either you can unmute yourself and talk, or you can put your questions in the chat box.
I'll stop sharing the screen now.
Oh, yeah, ma'am. Any questions?
Ma'am, in a patient with suffering pain because of cancer, and if they have an end stage renal disease, so how do we manage the pain in that case? Because most of the drugs will be renal toxic, and if the NRS is more than 8 to 10, we'll be using opioids, which mostly are renal toxic. So what do we mostly consider in that case?
It depends upon the severity of the pain, Carol. How severe is the pain?
8 to 10, scale of 8 to 10, because it's end stage and like end stage. So if the pain is 8 to 10, I'm just giving a vague scenario like that. It's not like I'm taking a case presentation of a patient, but if in case it's something like that and the pain is from 8 to 10, then what do we consider?
See,
Like,
we have to give a strong opioid in this case.
yes, ma'am.
And we can use fentanyl. Fentanyl can be safely given even in patients with renal
So,
dysfunction.
so fentanyl will be like not that renal toxic, no? It will be a lesser renal toxic one.
Yes, yes.
Okay. Thank you.
Morphine is not okay for that, but you can give
Yes,
fentanyl.
ma'am. Fentanyl, yeah. Okay.
And also methadone.
Yes.
If
Methadone and
methadone is
fentanyl.
available, that is also good in patients with renal dysfunction.
Okay, ma'am.
It's also
And in
strong.
case if the pain is mild,
Then
in case of a
paracetamol,
mild pain, paracetamol is okay.
and
Okay.
moderate pain, you can give tramadol, no problem.
Yes, tramadol will not be. Yeah. Okay.
Or you give a combination of more paracetamol with tramadol. Ultraset.
Okay. Yes, ma'am. Thank you.
Any other questions?
Yeah, one more question, ma'am, in the chat box. Ma'am, injection paracetamol, pure infusion or is it in dilution?
It's
Can give.
it is coming as a 100 ml infusion.
Yes.
Paracetamol. So you give the whole thing as a 100 ml infusion. It's coming as an infusion only. Okay, 1 gram, 1 gram.
Ma'am, in some hospitals, we don't have 100 ml infusion, especially in case of a mission hospital, we don't have 100 ml. We have the paracetamol and we have to dilute it and give.
Okay.
The
That is
prepared one is not there in the hospital, like the mission hospitals, because it's a little bit more expensive, I think so. So not all mission hospitals are considering that.
But can this be given in the IV form?
Yes, ma'am, we give it in dilution only, definitely with 100 ml NS. Eventually, we make the same thing. It's 100 ml NS, and we just add on the whatever dose is there, like 600 or 900, and then we give it in infusion only.
Although the recommended one is that infusion, because I think this may not be that well absorbed. But anyway, when it's not available, you have to manage with other thing also. Okay, but the recommended one is the infusion. Only when that is not available, you must use the ampule.
Okay.
Any other
questions? Any other questions?
What I said, I hope you understood what I tried to say. I mean, I know that some things may be a little, technical. I don't know whether I made myself clear, but basically you should get the hang of the whole thing, that what are the different types of drugs that you're using at each step of the ladder, what are the side effects, the toxicity, what are the methods of administration of these drugs, and how the method of action, that is also very, very important, how they act. Like what is COX-2, COX-1 drugs, and the COX non-selective COX inhibitor and the selective COX inhibitor. You should know the difference. Why is these drugs like Brufen, what are the side effects it has? What drug do you have to give along with it to prevent the side effects? Which are the contraindications? When do you avoid giving these drugs? Basically, you should get a hang of all that.
Yes, thank you, ma'am, for highlight that points. So that is very, very important, as ma'am mentioned earlier. So we are not an authorized person for prescribing drugs, but we should know the drugs, the methods of action, and what is the maximum dosage, and what are the side effects. So when they come for review, or maybe after the treatment, you can do the follow up. You can able to do the follow up, and you can do the proper assessment whether they have any side effects on that. Then you can tell the doctors and make sure that. And also whenever the doctors prescribed for a particular drug like NSAID, you can give a proper explanation to the patient and the caregivers. So what are the precautions they will take, that so they should take a protective that gastroprotective drugs, and also they should take NSAID after food, and also they should
And
drink
also adequate hydration.
hydration.
So these
So
are the things that you people should be very careful about.
yeah, so that is
And
very.
if you know it, what the mind doesn't know, the eye will not see. Okay, unless you know it, you will not be able to realize. Then you'll be mechanically giving the drugs. But you should know when you should avoid it and what all precautions you should take. All that you should be aware of. Okay.
Yes.
We have to be very proactive when you're treating these people.
Yeah. Thank you, ma'am. One more questions, madam, in the chat box. Hi, ma'am.
Yeah.
For paracetamol dose, since the safest dose is 3 gram per day, is there a ceiling dose for paracetamol?
The ceiling dose is 4 grams a day. Okay, but in patients with liver dysfunction, you should not go up to that. But in a patient with normal liver function and a young person, not very old, you can go up to 4 grams a day. But in elderly people, you will not go up to 4 grams a day. And those who have got liver dysfunction, only 3 grams a day or 2 to 3 grams a day, right? But in a healthy adult, you can go up to 4 grams a day.
Okay. Thank you, ma'am. Thank you. So can we move on to the case presentation, ma'am?
Yeah.
Okay, thank you. Thank you for clarifying your doubts. Today, the case presented by Mr. Bagana Valkar.
Yes, madam.
Yes, welcome and over to you.
Okay.
Yeah, so we will share. Can you able to see the slide?
1 second, madam. I will share.
You can start now.
1 second, madam. Good afternoon, everyone. Madam, you can see the my slides?
Yes, yes.
Okay. Good afternoon, everyone. This is Bagan Valikar from Tulli Senior Care, Bengaluru. Comes to patient details. Patient about 55 years old, male patient is there. And diagnosis about conjunctive heart cardiac failure and another chronic obstructive pulmonary disorder, and the patient also have chronic kidney disease. And patient presenting complaints about dyspnea and dry cough, weakness, swelling of legs, both legs, and patient have also complaints about weight gain, chest pain. Comes to history of illness. Client about 55-year-old gentleman presented with the chief complaints of chest pain and breathing difficulty, and client also have no urine output from 24 hours. Also developed the bed sore on sacrum region, and now it can create due to prolonged and bed bound at home. And next one is examination. Generally, patient have conscious and oriented, and dyspnea present. Also, orthopnea present. Obese is there patient also. Also, sinus is absent and present the pedal edema. Next one is treatment and significant investigations. Serum creatinine about 3.42 mm per well, and serum sodium 129 milli equi per liter, and electrocardiogram about sinus bradycardia. Comes to medication part. So presently, you have to administer the AC inhibitors and 5 mg tablet of lisinopril, and also administering to diuretics, Caboextart 1 mg tablet, and gabapentin 100 mg, and salbutamol 100 mg, and another one is prabutaline 500 mg tablet is there. You are all OD tablets. And next one is social experts of the client. Patient having wife and two children, source of income through rent and children are studying now. Wife is a private school primary teacher, and he was running his own business and now depressed due to inability to earn and dependent. Main concern about this case, management of O2 therapy at presently at home, and also have a pressure injury management this kind, and client family have financial issues. And last one summary, a 55-year-old gentleman was having presenting he complaint of with dry cough and weight gain and breathing difficulty, and started with treatment with beta blockers and diuretics, and also vasodilators treatment have started now. And now client under the on O2 therapy, and well response of client to morphogenic regimen, and also higher levels of care needed for the patient in for a sufficient treatment. Come to last one, discussion point. First one is discussion point is pain management. Second one is nutritional status, and the third one, patient and family counseling is if it needed or not, and the last one is winning of from O2. Thank you.
Thank you, Bagana, for the presentation. Anybody have any doubts or clarification needed for this presentation? Please ask him. Uh,
Yes, actually, I just have a query because I just want to know the doses of the patient, like frequency of the doses.
Gurpreet, can you repeat again? Your voice
Am I
was
audible?
not, yeah, your voice now is audible. Your voice was breaking. That is why we didn't hear.
Ma'am, I just want to know the treatment regimen of the patient.
Treatment regime, right?
Yes, yes, ma'am.
I think we can go back to the slide where the treatment is there.
Yeah, this is.
Uh, See, the treatment, I would think that the prescription has to be written in a proper way. We are not seeing whether it is giving OD or BD or 3 times a day. It's just written gabapentin 100 mg, salbutamol 100 mg. So can we just be more specific on that? The every drug should be written how many times a day, what time do you give it? So that is not mentioned there. Huh? Dr. Bagana? And the other thing is diuretics is written fiboxustat. That is given for uric acid. It's not a diuretic. It is to decrease uric acid that you give fiboxustat. Okay. So diuretic is either you're giving Lasix or you're giving something else.
Okay, ma'am.
And the other thing is, where is the pain exactly? You said pain management is one of the concern. Where does this gentleman have pain?
He having bed sore, no, madam.
Acha, bed sore pain, is
Yes,
it?
yes.
Okay.
You have mentioned in the presentation about chest pain. So what about now? So, Bagana,
Yeah, madam. Tell me.
so what about the chest pain?
These also pain, madam, and pressure ulcer is
Okay, pressure ulcer pain. Okay, so what is the score?
For about 8, madam.
8.
Yes.
So 8
But
out of 10?
Yes, madam.
What we,
Not mentioned in that.
yeah, okay. The patient is not getting any analgesics for that, no?
No, madam. Presently at home, madam.
Okay. And how will you manage? How are you going to manage this patient? 8 out of 10 pain score. What about
Through the,
others? Please contribute something. We need to help Bagana to help this patient. The patient is in home. She said 8 out of 10 pain score right now, the bed sore area. I think stage 2 pressure ulcer, right?
yes, madam.
Yeah. Uh, Kanchana said we can use cream and gels. Where?
But I actually, sorry for disturb you all. Actually, may this have to add some painkillers as well, like paracetamol, because actually patient have a pain score is 8 out of 10. So, but there is no any pain management medications are there. Might be they just miss it or they do not add.
Madam, what do you think?
So I think we should see he has got CKD. So I think at least we should give the step 2 drugs in this particular patient. You know, we should give a combination of paracetamol and Ultracet so that we can decrease the pain to a certain extent.
Yes.
Ah, because both are safe even in kidney patients and even with even if they have COPD and congestive heart failure, it can be given these drugs. So this would be the safest drug along with gabapentin. I agree that gabapentin can be given because there could be neuropathic pain also, but you have to treat the nociceptive pain by giving at least step 2 drugs in this particular patient.
Okay, ma'am. So I think as ma'am said, you have to give some analgesics for this patient and you have to do the proper that pain assessment first. You can make a call to the patient. The patient is in home, no? So you can give a call and find out the patient's current condition and do the proper pain assessment and you can share that history to the concerned doctor and you can give some analgesics for that patient. So that would be much helpful for this patient. After 2 days, you have to again you can do the phone call and review the pain part. So that is the only way we can manage this patient right now. Uh, Ma'am, any other points you want to add?
See, I think that drugs, regime of the drugs is the dose of the drugs are not right. The
Oh,
dose of terbutaline is only 5 mg, not 500 mg. And salbutamol is 4 mg tablets, not 100 mg. So I think someone has to look at all these medicines, that are being given. This is a big overdose.
yeah.
And also diuretics, like I said, febuxostat is an anti-uricemic drug. It's given for gout patients.
Yeah.
So whether the patient also has gout, that's a thing we have to see. Because gout also can cause renal failure. So agreed, he may be getting that, but I want to clarify that this is not a diuretic. Febuxostat is not a diuretic. And the dose of salbutamol and terbutaline is, I don't think, right. Please
Bagana,
check on that, Bagana.
yeah.
Yes, madam. I will
Where did you get the dosage?
through the clients, madam.
Through the?
Client history, madam.
You have not seen the patient.
I have seen the madam patient.
Then you have to see who has written the medicine, whether which doctor has written it, because this is not right.
Okay, madam.
Okay. Any other points you want to discuss? Anyway, the wound management, this patient is having stage 2 pressure ulcer. In our the stage thing, so only the peeling. There is no deep tissue injury happen. Only peeling. That is second stage. So that time we used to usually clean with normal saline. No need of antibiotic for that type. The second stage pressure ulcer. Anyway, we have a wound management session. That time we will discuss more about it. And you have to prevent further deterioration also. So give some precautions. Maybe you have to educate the patient and the caregivers about the prevention of pressure ulcer formation. That is very, very important. This patient is bedbound, so we have to tell the caregivers and the patient about the prevention, position changing. So what are the things you should tell the caregivers and patient about the prevention of pressure ulcer? Please put your answers in the chat box. What are the things you should educate them? So back care, okay, very good. Any other points? So we can suggest airbed, okay. Position changing every 2 to 3 hours early. We need to change the position. We need to educate the caregivers, empower the caregivers for the same, and so they can use additional pillows and cushions. Then, so whenever they change the position, they have to give a special attention on the pressure points and give some massage on that area, because if you if there is any color change there, you have to leave the area. You have to prevent further pressure on that area. So otherwise, you can take a mild moisturizing agent in your hand and give massage. That will help to improve the blood circulation on that area. And also, you can give some that air mattress, as one of you mentioned earlier. So air mattress also you can suggest, but because whenever you have suggest those kind of matters, you have to tell the caregivers the importance of changing your position. They might be thinking like, okay, if the patient, if the patient is in the air mattress, the pressure sore will not come. That kind of things inside their mind. So we should tell them this is not 100% preventable things. They need to change the position even if the patient is in airbed or water bed. So that is the important thing message you have to convey the caregivers. And also protein intake. Protein intake is also very, very important. Lack of protein intake in their diet can cause pressure ulcer. Okay, and friction. So we need to educate them and demonstrate them how to change the bed sheet for a bedbound patients. They don't know how to change it. They usually pull the sheet under the patients. So that can cause friction, and maybe that will make some crack in the skin. And if you apply more pressure on that, continuous pressure on that area, definitely the skin will damage. Okay, so that kind of education and demonstration is necessary for that patient. So here the first important thing is position change. The second thing is skin inspection. Whenever they change the position, they have to give a special attention on the pressure points. And the third one is massage. The fourth one is moisture. Moisture management, because the moisture is one of the most common cause of pressure ulcer. If they have a incontinence of the urine and fecal matters there, definitely the patients can develop pressure ulcer. That is also, if they are willing to put a catheter, they can insert a catheter. Otherwise, they can manage with the diaper, or if they are not able to afford diaper, they can use their own sheets. But the thing is, if there is any wet happen, they have to remove the sheets, change the sheets as soon as possible. And also that protein intake, hydration and nutrition is also very, very important. You have to provide a wrinkle-free bed and also cut short the nails. So these are the important things you have to tell the caregivers about the prevention of pressure ulcers. Okay. So, any other things you want to discuss? So, otherwise, we can wind up the session. Madam, you want to discuss anything?
Yeah, I was thinking of his psychosocial concerns
Yeah,
also,
yeah, yes,
which need to be addressed, because
yeah,
he's the earning member and his wife, they may be having financial constraints. The children are education. So there has to be a social worker attached to them who can counsel them and give them some kind of psychosocial support. That's also very important.
yeah. So, Bagana, do you have a palliative care setup there in your area?
No, madam.
No.
Oh,
So, okay. So, where you have worked? Where from where you are joined?
Bangalore, madam.
Adulya.
Yes.
Where?
Bangalore.
Bangalore. Okay. So, okay, Bangalore. So I'll call you later. So I need the proper place and I will help you. And if there is any palliative care NGOs are available, you can direct the patient there. They will give more attention to the patients. And as I mentioned earlier, the psychosocial issues, if they have a psychosocial issues there, definitely the physical distress will be increased. So madam was highlighted few the things again and again, that is very very important. Psychosocial issues, we have to explore the psychosocial problems, and if we are able to support them, we can support. Maybe if we are able to help them, we can help. So that way we can able to reduce the psychosocial distress, because children's education, because of his illness, the children's not able to study. So that kind of things will be affecting the patient. Okay, because of me, my family is not well, and my that children are not able to study. That kind of things will be there. So they, if possible, you can go there and listen at least 10 minutes his concerns, and maybe after that, if there is any nearby palliative care centers there, you can refer the patient to there, so that that patient will get good palliative care. Okay. So Kanchana said religious support also, the chat box. I read religious and spiritual supports. Is of course the total care. This patient need total care, physical, social, emotional, and spiritual support is needed. That is why that is what palliative care, total care. So and also we need a teamwork. So we need to work together and make the patient comfortable as much as we can. Okay. Ma'am, can we wind up?
Yes.
Thank you. Thank you once again for the wonderful session. Thank you all for clarifying your doubts and all. Thank you once again.
Thank you.